Platinum Jubilee, and it's truly an honour to be invited to talk today. I don't think I've ever been introduced from someone in a car before, and that I think really shows the sort of IT world that we now live in the Zoom world. I hope very much I'm starting to share my screen. Tusha, perhaps you could just confirm that that's happening. Is the screen being shared?
Yes.
Yeah.
It is. Great. Okay. I'm just trying to get into slideshow mode. So, yes, it's a very interesting world, and I'd just like to say good afternoon to everybody in India. India is a country that is very close to my heart. It's where I met Tusha, and in my inauguration as a fellow of the Indian College of Obstetrics and Gynecology, and that was my last international trip before the onset of the pandemic. And I think it's fair to say that I completely miss India. India's had a closeness in my heart throughout my whole career. I have many friends in India who I've missed. Thankfully, I've been able to speak to during the pandemic, but still, I greatly miss India. And seeing the scenes in the car behind Professor Hota as he introduced this session made me yearn even more to see India. But hopefully that won't be too long as the vaccine spreads across the world. So I've been asked to talk about new challenges in women's health, and I have no shame in making this very flavoured by the challenge that has been the COVID pandemic, and also flavoured by our experiences in the UK, because I believe that some areas where the UK have mirrored what's gone on in the world, and some areas where I think we've got a lot, we can share our learning with you in India. So if we look at the health of the UK prior to COVID-19, I've just got one slide to show here. And this shows that way before the pandemic, our advances in women's health had stalled. So you see here that from 1980 through to 2018 or through to 2010, we were looking at increasing life expectancy in women over men year on year. But when you look at the period from 2012 to 2018, things had stalled. And why is that? This may be economic, it may be related to the population, it could be related to the environment. And these are all issues that we need to unpick, but still they're incredibly important. However, what will the effect of the pandemic be when we look at back in time as to what we've done over the last 2 years? So let's talk a little bit about, and this is the vast majority of my talk, about what happened to women's health during the pandemic. And once I've talked about this, I'll talk about the things that we need to consider over the coming years. So you see, when we compare women to men, there have been significant death rates. Interestingly, if you look at death rates overall, and these are deaths in the UK, men have had a higher death rates than women. But when you look at the different racial groups in the UK, Black African, Bangladeshi, Black Caribbean, Pakistani and Indians actually have had higher death rates than whites. And this has really highlighted the problem we have in the UK around inequalities. And we're spending a lot of time and resource trying to get to the bottom of that. But like you, at the beginning of the pandemic, we had problems. We had problems with PPE, we had problems with availability for COVID testing. Staff were moved from areas where they were more comfortable and experienced in their work to areas such as intensive care, emergency rooms to provide care for people suffering the effects of COVID-19. People's on-call rotas were changed. Social distancing affected a lot of our working and our home relationships. But we felt at the RCOG, and me personally felt, that we needed COVID-19 specific guidance for women's health. And so what I did is, and this was in February 2020, goodness me, how time flies, February 2020, I very quickly identified that we would need this guidance, and I set up the guidance cell. I'm not going to spend a long time talking about this, but I think it is important because we established that we needed guidelines. There was no experience about COVID, so we set up a unit that received data and created guidance at pace and was prepared to change the guidance quickly. And we were looking at both clinical but also organizational issues for the health service. And to begin with, we met every day. And I was doing 18-hour days as president, writing this guidance 7 days a week for the first 3 to 4 months of the pandemic. So we really got to understand what was going on. And we also did a lot of work in the media. We produced frequently asked questions. We did lots of work on social media and really disseminated our messages. And I'll come back to this towards the end, but it was a huge sense of great achievement when we realized that actually around the world, people were using our guidance. And since then, lots of our colleagues around the world have said that they did. In maternity, we had problems. Women didn't book for their pregnancy until later. We had women who wouldn't attend for their antenatal visits. And there was a reluctance to present with problems because women were afraid to go outside and potentially pick up the virus. And also there was less interaction with women after they delivered their babies. And as I've said, staff from maternity units were redeployed to the intensive care environment and other places, and that had a significant impact on staff available to give safe maternity care. And we found when you look at the outcomes, we have the UK Obstetrics surveillance system, and this is a great setup that looks at outcomes, and we were one of the first groups to publish what was happening to women with COVID-19. But one thing that we did spot was when you looked at the incidence of COVID-19, again, this was higher in different ethnic groups than it was in white British people. So clearly there are issues there. In primary care, so not just looking at women's health, but throughout primary care, so family doctors, we had people delaying their presentations. They had problems controlling long-term conditions because they were not going to see their general practitioner or family doctor. A significant rise in mental health issues, ongoing winter pressures, and delivery of flu vaccination got impacted. But as I've said, there were widening socioeconomic inequalities. And I know from speaking to my friends in India that this is something that you have also experienced. Now, family planning and abortion care, which is one of the most significant elements of providing family planning, we were very worried about. And we as a college pushed hard on the UK government to introduce home use of mifepristone, supervised by family planning clinics, but nonetheless given at home so that women didn't have to travel so much to family planning clinics. And we collected data to look at the outcomes. And this is one of the, it's rather odd talking about abortion as a success story, but it isn't a success story because you can see that from the start of the pandemic in March through to May, June of 2020, we had a significant decrease in the average gestation at the time of abortion. So that, as you will all know, that the earlier an abortion is done, the safer it is. And so we've also improved access. We have evidence of fewer women obtaining illegal abortions or abortions in other ways. And again, that will improve the safety. So that's another thing that we have learned from the pandemic. Now, many of my friends in India are fertility doctors, and I know that fertility clinics in the UK, their activity was paused at the height of the pandemic. It reopened after the first wave, but nonetheless, women with premature ovarian failure who were trying to get treatment, or maybe women who were in their 40s, were getting very worried about access to treatment. But now things have pretty much returned to normal. Urogynecology, so that's one of the areas that I used to work in quite a lot, has suffered significantly. Urogynecology is not seen by many areas of the health system, not by gynecologists, but by people who fund the health system, by government leaders, as not being one of the great priorities because it's not something that affects lifespan. It's not something that kills people. It is a quality of life issue, and that suffered a severe reduction in services. It was difficult to get people to come and have pessary changes. There were lots of referrals that were reduced, and also delivering some of the conservative treatments such as physiotherapy, which meant face-to-face treatment, that fell significantly. And basically routine work stopped for at least 3 months. And in the UK, the services are taking a long time to come back. Benign gynecology. So in that subject, I talk about fibroids, endometriosis, chronic pelvic pain, and so on. And again, those services paused during the initial wave. They restarted in the middle of last year, so roughly this time last year. Cancer and diagnostics took priority. understandably, but the effects on quality of life have been significant. Hospital capacity to actually deliver the operations that got paused is a real problem in the UK. We have huge waiting lists. Some women are waiting 18 to 24 months for their surgeries. So that's nearly 2 years for some people. And so one of my roles as president is to advocate for women with benign gynecological conditions, to show that they are important, they do contribute to society, and they should be treated. This slide is really interesting. It came from a study very early on in the pandemic, but it looked at the first 12 weeks of the cancellations of procedures around the world. So where the color is dark, 90 to 100% of benign gynecological procedures were cancelled in the first 12 months. And so you can see in India, about 70 to 80% were cancelled in those first 12 weeks. But in Africa, there was not a lot of cancellations. However, you can see the Western world, very much benign gynecology just stopped. Gynae cancer is different, and I think a lot of health authorities have noticed that treating of gynecological cancer has to have been kept a priority after a brief pause whilst we understood a bit about COVID. That has now improved. Capacity is still an ongoing issue, but still it's getting back to normal. One of the problems with gynae cancer, as you know, is quite often a woman after a major operation will need intensive care, and with intensive care beds still occupied by COVID patients, this does limit the number of really advanced surgeries that can be done for gynecological cancer. But nonetheless, with COVID protected pathways to make sure that people are free of COVID and the staff are free of COVID, we've been able to give that. And here's the slide, the same slide with gynae cancer. So you can see that around the Western world, actually in 12 weeks, there were not as many cancellations of gynae cancer as actually in the central part of Africa, as you can see there. So in India, you can see roughly in the first 12 weeks, there was about 50% cancellations, but nonetheless, I'm sure that you are picking that up. Let me look at the wider impact on the UK health system, which I think is interesting to talk about. So as I said, many elective services have been paused, but patient behavior has changed. And I'll show you a slide about that in a second. But millions have been affected in the UK. So we're a population of 60 odd million people, but millions have been affected. Millions of opportunities to use preventative health messages have been lost. Millions of opportunities to actually treat people have been lost. And the second wave, and now the third wave, has very much got in the way of restoration of services. So if we look at visits to the emergency room, it's amazing how the number of visits dropped. So it dropped by a half, really, in the first 12 weeks. 50% fewer people came to the emergency room to begin with. That's now pretty much restored, but nonetheless, it really shows the effect of the pandemic on emergency room. But then when we look at hospital admissions in that first 6 months, so between 1.3 and 1.5 fewer admissions to hospital, over 2 million fewer outpatient appointments, nearly 300,000 fewer urgent cancer referrals, and between 32 and 40,000 fewer patients starting their first cancer treatment. So you can see this will have ramifications for health and women's health way down the line. Menopause treatment's been very interesting, actually, because this stopped completely at the beginning of the pandemic. It was not seen as a priority, but nonetheless is very suitable for remote consultations, which I'll come back to. Good feedback from patients about remote consultations, but not great for building a personal relationship because you don't necessarily see each other face to face. Access to primary care is very important for menopause, but also menopause training has suffered. So let's wind forward to where we are, to late 2020 and the introduction of the vaccine. So the guidance subgroup, so the guidance cell as it was to begin with, became the subgroup, and then we focused on more a slower turnaround as more papers came in with bigger numbers, able to really synthesize the data into some very concrete green top guideline type recommendations. And I know you, my friends in India, are very fond of RCOG green top guidelines and use them a lot. And this is what the COVID-19 guideline is now. It's just like a green top guideline in many ways, but still changes much quicker. we set up a vaccine subgroup to talk more about vaccination to COVID. And you will know as well as I that there are no big clinical trials in pregnant women anywhere around the world. And so initially we had government hesitancy to recommend the vaccination, but now very much we, the college, recommend vaccination to all pregnant women. And where possible, the Pfizer or Moderna vaccine is the one that we recommend. And that's based on more cases of women who have had the Pfizer vaccine more than anything else. I doubt very much that the AstraZeneca vaccine would be a problem in pregnant women because what we see with regards to the thrombotic problems with AstraZeneca are not the type that are affected by hormones or by pregnancy. But I'm hoping that research will answer that question. And we've done a lot of work around risks and benefits presentations with vaccine use. And we now know that there's nearly 200,000 people, when you look at the UK and the US, have used the vaccine, and there are no safety concerns there. At the moment in the UK, we have increasing admissions in pregnant women with COVID, and 98% of these admissions are women who have not had a vaccine. So it really shows the benefit of having a vaccine in pregnancy. And 1 in 10 women who get admitted will end up on ITU. So we're very worried about that, and we're using that. In fact, this morning, a colleague of mine was actually on television in the UK giving these messages saying, get vaccinated, because it's very clear that this will prevent serious illness in pregnancy. And the Delta variant that's now very prevalent in the UK, it appears to be having a worse effect on women. And that is a current problem. But I think this is going to be one of those future challenges for women. COVID is going to be here for a long time, and we need to learn how to live with it and to manage its consequences. The Delta variant has a 2-fold increase in the risk of pneumonia in comparison to the original wild type variant of COVID. So that, again, is a significant consideration. So now, women's health after the pandemic. So these are the challenges that we have to think about as we move forward. And we now, all countries, need to think about what are they going to do after the pandemic. India, I'm sure, like England, has large numbers of women who are waiting for surgery. And we have to very carefully balance the effort on the backlog whilst recognizing that the staff to do that are pretty tired, pretty exhausted, offering care for the pandemic. And really what we need is a national ambition in every country around the world and investment to recognize that, that the way we deliver care has to be done differently. So what's next? Well, we need to properly understand the effect coronavirus has had on health systems around the world. We need to reprioritize our efforts, and we need to influence the work in response to what's happened around the world. But fundamentally, we have to understand the effect that it has had on women. I think there's a lot to be said about remote consultations. I probably do 50% of my consultations by telephone or by video conference now. And that has helped keep women away from hospital when they don't necessarily need to actually meet me face to face for an understanding of how to manage their condition. Most women welcome it. We have some technical difficulties. We haven't had any technical differences on this Zoom so far today, which is great. I think those difficulties are being ironed out. Remote consultations definitely improve accessibility. And I think countries such as India, with large swathes of the country that are inaccessible, or women have to walk for miles and miles or for days, travel to get to a hospital, that remote consultations may well be the key to good healthcare in the future. That is really helping overcome communication difficulties. And I think research into remote consultations will be very useful to see, has this helped outcomes, or does it get in the way of good outcomes? But fundamentally, and as a president, I'm using the pandemic as an opportunity to improve the care that we give women. We have had in the UK, and I know countries around the world, have had long-standing systemic issues with women's health. And as Tusha said in his introduction, that women are not necessarily recognised in the way that they suffer for the same problems that men have and are recognised differently. This is all about closing the gender gap that has developed in the delivery of healthcare in many areas of healthcare around the world. We've produced women's Women's Health Report, and that's on the RCOG website called Better for Women. And I do recommend having a look at it. It is not entirely UK focused. I want to end on two issues I feel passionately about. One is the inequalities in obstetrics and gynecology. So we know, and I showed you at the beginning, that there were inequalities in death rates from COVID. But before the pandemic, we had inequalities in maternal mortality in the UK. And this is the same in the United States and in other countries around the world. Black women have more than 5 times the risk of dying in pregnancy than white women. Women of mixed ethnicity have 3 times the mortality risk when compared to white, and Asian women have nearly twice the risk. And that's in the UK, that's in a developed country. Black, Asian, and all minority ethnic women have an increased risk of having a preterm birth, a stillbirth, a neonatal death, or having a small for gestational age baby. And these we should be ashamed of in the UK. How has this been allowed to happen? And so what I have done as president, in spite of the pandemic, I've formed the Race Equality Task Force. And that is to really understand how race is affected by the care that we give in the UK. So we're looking at the policies and strategies that lead to poor outcomes. We're looking at the women's health outcomes in detail, but we're also looking at a career in obstetrics and gynecology, because when I launched this group, we heard very much that some trainees in our specialty are experiencing racist behaviors as they go through their career in obstetrics and gynecology, and I'm not prepared to stand for that. There's way more about the task force on our website, and I'm very interested to hear from anybody who thinks we should be doing anything differently on this, but it's an area that I'm passionate about, and in the UK are very much making progress. The RCOG has influence, and I know you know that, and I'm very happy to listen to you and how we can influence the health that you give women in India. But we were amazed when some of our guidance hit this, which is a letter the Prime Minister sent to every house in the UK. It's incredible that they recognised that the RCOG was providing information to pregnant women and pointed pregnant women to that. It was a big honour for me, and it was a real recognition of the work that we did as a college at the beginning of the pandemic. And in fact, the work that we have done has reached millions of people. In fact, this 4 million figure now is nearly 6 million. So nearly 6 million people have visited our COVID-19 hub, have read the information, or have downloaded our guidance. And I know many of you in India have done that. But it's been a big team effort. I am surrounded by an amazing team of vice presidents, but I've worked with all the specialist societies in the UK and also the UK government, who recognise that women's health should be a priority now and in the future. So thank you so much for listening. These are our new gates at the RCOG. Now, when I took this photograph, they were closed. We were in lockdown. And I was unable to go there. I'm now able to go there a day a week. I'm not there today. I'm talking from my study in Norwich. But nonetheless, when you next come to England and travel can be started again, you will be very welcome at the Royal College of Obstetricians and Gynecologists. Thank you for listening, and I'm very happy to answer questions.
Yeah, Tushar, let me come in before I leave and hand over to Professor B.V. Misra to chair this session. Thank you, Dr. Edward, for the enlightening talk. But in a lighter vein, I will say that a lot of importance has been given to the women's health globally. And there is a lot of awareness on women's health. Being a uroenterologist, there is now the thrust is on the men's health. And there is the International Society of Men's Health. We have got MHSI, Men's Health Society of India. A lot of thrust is given to the men's health. But all said, pandemic has made a havoc to every segment of the society and to every life. We in SCB, in our medical college, we have a dedicated COVID hospital, which is very well equipped for last 1.5 years. I think during the discussion, our obstetric gynecologist colleague can also, try to know from you in which way we can improve upon. Now, before I leave, I welcome Professor P.C. Mahapatra, our elder brother, and our mentor of Medical College as the next speaker. Thanks to all of you. Unfortunately, I have to leave the meeting because there is one important meeting at the government level. I request Professor B.V. Misra to take over as chairman. Thank you so much. Thanks to all of you.
Thank you, Eddie. Thank you very much for your nice and very crispy talk. And now we'll be going to the chat box after the end of the second lecture. And I now invite Professor P.C. Mahapatra for the second lecture. He is a very well-known face nationally and internationally. He was the professor and head of the Department of Obstetrics Gynae of SME Medical College, Cuttack. He was the president Foxy 2011. Foxy represented to Suffolk 2014 to 15. Vice president of the Foxy 2004 and chairperson of Medical Education Committee Foxy 2002 to 2007. And now he is the sitting president of SME Medical College Alumni Association. So with this, now I am inviting him to give a lecture on women's health in India, facts, fallacies, and fantasies. You can guess how is the name is very tricky name and very catchy name. So now invite Professor P.C. Mahapatra, and mic is yours, sir.
Sir, only one request. Please see that the meeting is over by 5:15.
Okay, sir. I'll be restricting, sir, requesting to say within 20 minutes so that after that chat box will be open. Thank you, sir.
Thank you, Tushar. Am I audible?
Yeah, audible, very much audible, but please make it full screen, sir. Yes, yes, it is full screen.
Well, thank you, my beloved younger brother, the Dean of the Faculty of Medicine, SC Medical College, Professor Hota, Professor Banbiari Misra, and my lovable Tushar, HOD of Obstetrics and Gynecology in SC Medical College, Cuttack. And I welcome on my personal behalf and on behalf of Foxy and SCB Alumni Association to Professor Edward Morris. I think I'm really obliged and honored to see you in this forum to be a part of this particular academic event. I thank, special thanks to Edward Morris for this enlightened talk, and the viewers, the faculties and all that. It's a chance. I'm really privileged and honored to be here, to be part of this particular academic event on a very noble, I think, very vision of conducting the pre-Platinum Jubilee CME. I think we are celebrating this Platinum Jubilee conference in November. I hope Professor Hota will complete 75 CMEs before the Platinum Jubilee so that it will really fit into the concept of this Platinum Jubilee celebration. Well, thank you very much for being for inviting me to talk after Edward Morris. Professor Morris, thank you very much for simplifying the very important aspect dealing with this current scenario of pandemic and the present and the future of women's health issues of various segments of the women's health issues you have already enumerated, and therefore I don't want to duplicate the issues of the women's health issue. I will only restrict my talk to the maternal health issues. Well, COVID is such a change, whole of the global situation as far as health is concerned, that people are forgetting all health issues and talking of COVID only. COVID pandemic issues affecting the women, particularly the maternity, everybody has realized. All the obstetricians and gynecologists have realized after the lockdown, shutdown, they have shut the emergency, only the elective services have been shut down, and emergency, they had to do it. And they have really done a great job by the COVID hospital related to the obstetrics and gynecology in the department. I'm proud of that. I thank the faculty for the really the effort which have made it in the during the COVID pandemic for the obstetrics, for the our beneficiaries. Well, therefore, I will not waste my time in particularly on the COVID. He has extensively dealt with, Professor Morris has extensively dealt with on the COVID pandemic and the various women's health issues and the present and the future of this. And believe me, I think two things COVID has gotten a lesson. One is uncertainty, another is adversity. These two things we have learned from COVID pandemic, and with these two things, uncertainties and adversities, we have struggled and crushed over the pandemic, and any academics is not going to be affected with the pandemics. You see the digital forum everywhere. We are doing a lot of webinar for that also, and this is part of that today. I bring greetings from the place of Lord Jagannath, and my talk will be specified. Women's health issues is a very broad issues, starting from adolescenthood to the reproductive period, menopause, premenopause, postmenopause, malignancy, infertility, whatnot. I think I will not waste my time on that particular issue. I will just restrict it to the maternal health system in India, because India is at par with the state. We have not reached the desired goal as far as maternity services is concerned. We are thought of and targeted that the sustainability goal and 2025 will make at least less than 100 maternal deaths all over the India. Though in some of the states it has been achievable, but still there are many states which is much beyond the estimated thing. And therefore, still COVID has really posed a problem on the health system of the country as well as for the state, as regards the finance, as regards the logistics, as regards the attitudinal changes of the healthcare providers for that. And therefore, it is now going to be a drastic change when we divert attention from the COVID pandemic to the maternal health system in India. So I will deal with the facts, fallacies, and fantasies. What are those? What is the fact related to the maternal health issues? What are the fallacies there? And what could be the fantasies there? Now, the test of any civilization is the measure of consideration and care which it gives to its weaker sections. And women are thought to be a weaker section. Dr. Hota, the men's system is different. Men's wealth has been already targeted for that. But we as a healthcare provider, we will be more partial and specific to the women's health. And therefore, we take an advantage out of that and make it an issues over the men's health issues. No country sends its soldiers to war to protect their country without seeing to it that they will return safely. And yet, mankind for centuries joy turns out to be a personal, familial, social, and a national tragedy. Now, this is the time of introspection. As a healthcare provider, as an obstetrician, we must have an introspection. Think who is responsible for these tragedies. Whether the beneficiary woman is responsible, whether the healthcare providers, the doctors and nurses are responsible, or whether the system, the bureaucratic and the political system is responsible. This is the time and need of the hour of introspection. Now, healthy mother don't just not happen. There are 5 basic parameters of healthy mother. Healthy birth is one of the component. And in the healthy birth component, we have divided into antenatal care, the TBA and the referral system, the intrapartum and the postpartum attitude. But apart from the healthy birth, the other components, 4 components are equally important, more important than the healthy birth to constitute a healthy mother. Healthy diet is important. Healthy environment is important. Healthy development is important, starting from the adolescent period to the health education and the nutritional status. And healthy mother of mature knowledge and well-fed mother. And last but not the least, healthy birth is one of the component where we are concerned about it. So out of these basic parameters, one should not forget and give emphasis only on the healthy birth. The other components are to be addressed by the healthcare professionals as well as the system. Now, maternal deaths, when we cover that, when we focus, all these, I think the causes we highlight, starting from the hemorrhage to the sepsis, obstructed labor, eclampsia, unsafe abortions and all that, and other direct causes of that. And therefore, although we have eliminated many things, as for example, when we were students, the PPH and the hemorrhage was the leading cause and all that. Now it has come down because of measures, because of the improved conceptual understanding of the pathology and the newer molecules which is there for arrest of the bleeding and the surgical modalities and skill of the surgeons. but still eclampsia is not preventable totally, and the incidence of and the infections and the indirect causes are still responsible for to a considerable extent of the maternal death. Therefore, the indirect causes, we are not going to ignore that, and the indirect causes could be medical, social, and socio-cultural. So therefore, these are some of the important causes of the maternal deaths, and medical causes, out of which anemia is one of the most important things. In India, still we are in a position that we are not able to eradicate anemia. There are a lot of programs, anemia, chale jao, and 100 iron and 100 milligram in 100 days. There are government agencies who are doing a profound effect on the anemia, starting from the hemoglobin estimation to the supply. And our gynecologists are actually struggling hard for finding out how to eradicate anemia, but still there is a problem. It has not been able to eradicate properly. We have switched over from oral medications to parenteral, newer formulations of the iron therapy, but iron deficiency anemia still is a problem, particularly in rural countries, in the rural areas in India. And apart from it, the associated medical causes like cardiac, renal, hepatic, metabolic, and infections, and malaria. And when we talk of infection, I think now we cannot talk of anything other than COVID-19 infections for that also. Thanks to the people who have in the COVID ward, who are tackling the obstetric patients with the COVID positivity, I must salute them for their contribution for during these particular critical juncture. Malignancy and accidents are other causes for that. Now, anemia is still, I say that it's an antedate. It may antedate pregnancy. It may be aggravated by pregnancy, and accidents of labor try to perpetuate it. There are social causes. Social causes like age, parity, pregnancy in succession, family size, poverty, literacy status, gender discrimination, ignorance, prejudice, nutritional status. Now, there is a change in the social system. The demography of change as far as the maternity services is concerned about the age, the delayed age of marriage and the delayed pregnancy because of the career seeking gives rise to more of problem. The associated comorbidities are more common when in elderly pregnant women. And parity, of course, we are very fortunate that now people are more concerned and we are not able to see the grand multiparity as before. But still, a parity is there in uneducated, illiterate, and rural communities for that. Pregnancy and sex, family size, poverty is a real issue. Poverty, literacy status, these are the main issues in the country like India. And therefore, and of course, gender discrimination, prejudice, ignorance, and the nutritional status. And again, in India, one of the lack of access to the maternity services and the fertility control, that's also important. Still, we know that we have been trying hard for the contraceptions, but still there is a lot of way forward for that to improve the issues for that. Shortage and maldistribution of health manpower and infrastructure, that's also there. And COVID has given a lesson that still there is a need for more of a health infrastructure and ultra function for that. Poor communication and transport facilities. Luckily, the government has taken agencies for the transportation, and therefore we have little better in terms of that 1 year or 2 decades before that. Social customs, social delays still is prevalent for that. Social delays, it's not going to be changed till after we have spread it. Still 1.5 decades before the concept was on social delays. Delay 1, delay in seeking care. Delay 2, delay in reaching care. Delay 3 is delay in receiving care. But still, I can say that we are not in a position to solve this problem of delay, even at 3, even after receiving. I think in the medical college or in the centers where they are there, still there's a delay in receiving because of there are many problems. Apart, we cannot say that the system is responsible, and I think there is a need to challenge, need for avoiding that and breaking the challenge for that. So health is not merely an issue of doctors, social services, and hospitals. It is an issue of social justice. Safe motherhood is a human rights issue. I think this is to be remembered that it's not the concern of the doctors and social services in the hospitals issue. It is way bound, and beyond that, there are many people who are responsible, and it should be a social justice. Now, combating measures, what are the facts? What are there? There's still the people are trying hard, and initiative, policy, program are there. The strategies by the government, action plan has been taken, but the main problem is identifying the gaps and lacuna and implementing it. When there is what is the problem of the lacunae? Just making a agenda or making a proper plan doesn't suffice it. there is a lot of difference between that. How far we can, what is the gap between the implementation? That's important. Personal and family level, we should have a combating measures. Social mobilization, this is a very important thing particularly in country like India. Social mobilization is very ineffective in there. We roll up professional bodies and NGOs like Foxy has struggled hard. We have got different subcommittees related to the maternal health issues and the combating that measures. Confidential inquiry, audit, and self-introspection. Kerala has given a lesson. The Society of Kerala Obstetric and Gynec Society, confidential inquiry into the committee, and no blame game. It's an audit and self-introspection. It should be uniformly distributed in every state, every societies, and the institutional level also. So therefore, luckily my institution, SC Medical College, is regularly doing the death committee, death review every month. And that's a very important for our really looking forward for the future to how to overcome that. Now, this is a very important thing. The social mobilization. Now, COVID is also giving a lesson of that. Community mobilization and social marketing. We are saying that social distancing, vaccination, mask, and all that. But our nature is like that. The Indian, every country, every culture has a different philosophy. And overnight, you cannot change that. And therefore, community mobilization is important for that. As far as maternal health is concerned, it is the responsibility of the community to mobilize and help the pregnant women for that. We need a social marketing. Everywhere there is a marketing. Why not in a marketing here in relation to the health issues related to this? And there is a drastic change. So there should be a drastic change in the behavior change communication. And this behavior change communication, you see, you compare now COVID, everybody is telling that, yes, nobody is following the guidelines and all that. Same thing we say that behavior change communication should be there in all aspects of health, and maternal health is not an exception for that. And of course, advocacy, rightly Rcog president has already told, who will be the advocate for that? We are the advocacy for that because we are the healthcare providers for that. So health is a personal social state of balance and well-being in which a woman feels strong, active, creative, wise, and worthwhile, where her own bodies, and diverse entities are valued, and where she expresses himself and move about freely. So women in India suffer. They will suffer because he's pregnant, because he's poor, because he's powerless. Families can make a difference. Societies can have the responsibility, and healthcare providers can have the commitment. And it's a time that we should have a commitment on that to achieve the goals of objectives of mothers of Mother India. We have a great role to play for that. And Foxy and Women's Health, Foxy is trying hard from conception to cremation. I must salute the Foxy is trying hard and impressing on the government to provide the vaccination to the pregnancy and lactation. We have for months together with evidences, with trials in other countries regarding the pregnancy. At last, the government and ICMR accepted that, and initially they approved for lactational women, lactational mother, and later now they've approved for the pregnancy. Thanks to the government for the COVID vaccination in pregnancy and postpartum. And this is a really change advocacy by the Foxy. What are the fallacies? Maternal health in India. It is a vast country. It's a varied people, and it's a paradoxical entity. India is unique in that sense. And there is a gap in programming and implementation. State and center difference and in coordination is there. The state and health is a state subject, but the center is also playing a great role in that. And therefore, the political disturbance and the political alignment should be there for achieving the target of the maternal health for that. Bureaucratic and political will. The system depends on this. And if they should be mobilized, bureaucratic and political will, not the technocrats alone can serve the purpose. Community participation, again, I will emphasize that is lacking. Depth of personnel, gynecologists, anesthesists, pediatrician, and paramedical and personal staff for that. We have a lot of effort starting from EMOC program to other activities and training to the providers for that. But still there is a dearth of the personnel for that. Infrastructure is there. There is no dearth of infrastructure, but the quality infrastructure is there. And if it is infrastructure is there, ultra function should be there. The commitment of the persons, the attitudinal changes for that, and dedication is important to achieve the goal for that. Though we know that rural urban differences are there, but still amongst that, India is a combination of rural and urban countries. Now there are a lot of changes in the rural setup also, and starting from the health issues till the other improvements by the government and all that. And medical legal issues is also a problem for the beneficiaries as well as for the healthcare providers. So FOX's role is advocacy, to be a part of National Program of Women's Health, promotion of institutional confinement, EMOC program, JSY and JSSK, accreditation of private hospitals, not only the government public sector, the private hospitals should be integrated for that. Maternity insurance is a part which has improved and which is now being used for that. Earlier it was not there. Improving skill and will, and that's important, the fallacies of that. And what are the fantasies? Fantasies at the last, I will say, that pregnant mothers are vital government property, and therefore we as a healthcare provider and an advocacy, we should impress the government that this should be a priority on the pregnant women for that. Pregnancy and childbirth is a human rights issue. If you consider that it's a human rights issue, I think a lot of emphasis has been given for that. Maternal and perinatal deaths and disability is a criminal offense. If you think like that, I think you will act like that. And popularization of maternity insurance. Luckily, it was there. Earlier, it was not at all. We started maternity insurance movement way back in 2011, Ahmedabad, and now it is being adopted all over the country for that. And introducing pregnancy card. Let the government introducing the pregnancy card so that the privilege, this should be a privileged class by himself of getting a lot of benefits, starting from subsidized medication to transport to all investigative agents, educators for that. Subsidizing medication is a very important thing for that. And branding maternity hospital. In my childhood, I have seen the maternity hospitals are branded maternity hospitals are there. Now there are many endoscopic centers, infertility centers. Where are the brand maternity hospitals? I think there is a need of maternity brand hospital for that. And therefore the government has all government district headquarter hospital, about 100 bedded RCH. I think the maternity MCH hospital is there. I think this is a way forward for that. But a branding of the hospital is a more advanced thing, and one must be focused on that. And the production tax. If the government doesn't have money, I proposed at the time during my presidency, you are levying all types of tax. Let them have a reproduction tax during marriage. People are spending lakhs and crores of rupees during marriage. Of course, Corona has saved that. But reproduction tax should alleviate, give it to insurance. Let it be infertility, let it be in pregnancy. Everything can be insured, and so that the patients will be uniformly distributed, and finance is not a problem for that. So finance or force, either hospital or jail. If that rule has to be there, I think people's motivation should be there, community participation will be there, and we as a healthcare provider must be dedicated and commitment. We will do the job, and in the way forward, that in the coming centuries, we can really do a lot of great job in the country like India, not only in reducing the maternal deaths below 100, but will eliminate it to a considerable extent. And I think I'm very optimistic for that, and we can do it for that. Thank you very much, ladies and gentlemen, and my fellow mates and SCBNs for involving me in this particular COVID pandemic situation. I think the Platinum Jubilee CME is conducted by our department, Obstetrics and Gynecology department. I think I thank everybody for involving me for that. Thank you.
Thank you very much, sir. Am I audible?
Yes, yes.
Sir, thank you very much, sir, especially for finishing in time. It's a very nice elaboration of the fact, fantasies, fallacies. All three are covered very nicely. Now, from the chat box, few questions have come. One question to AD. In medical comorbidities of pregnancy, is there a difference between Asian and in blacks?
I didn't hear that question, I'm afraid, Tusha. Can you say it again?
Yeah. In medical comorbidities of pregnancy, is there a difference between Asian and in blacks?
So the question was about medical comorbidities in pregnancy. Is there a difference? Well, yes. I mean, there are certainly some comorbidities that are more frequent in different racial groups than others. That's the nature of human life. The interesting issue here, though, is that when you look at research into things like prematurity, fibroids, a lot of the things that have a racial difference, the research is very rarely targeted appropriately. And interesting, in the UK, NICE, who are our national guidance producing body, they actually they've recently made a recommendation that Black women should all be induced at 39 weeks of gestation. And this is based on absolutely no data. It was an expert recommendation. And a lot of people felt, well, why are you making this recommendation then if you have no research behind it? And so what this has highlighted is the fact that you need to do research to prove these differences, and also to show that you need to change the way in which you manage different races. Because if you make a change, if you manage one race differently to the other, if you're not careful, that could be seen as being a racist approach to things. So yes, that's a very interesting question. And yes, there are lots of racial differences, but we need better research to show that those differences warrant a different way of looking after people when they have a complication or a problem or that condition develops. Does that make sense?
Yeah. So this is a question to both the speakers. Is there any relation between severe anemia and eclampsia? To Professor P.C. Mahapatra, is there any relation between severe anemia in pregnancy with eclampsia?
Well, there are a couple of papers relating to the anemia and PIH and the progression of the PIH to eclampsia. I have seen few papers that yes, anemic women are more prone for development of eclampsia provided she is having a pregnancy-induced hypertension for that.
Why I say so, why I ask this, sir? Because in northeastern region and eastern India, it is seen that there is a relationship between the severe anemia and the incidence of SDP, especially hypertensive disorder of pregnancy. Of course, exact pathogenesis is yet to be explored.
I might add to that, actually, that obviously severe anemia exists in HELP, which obviously is hemolysis, and part of that is anemia. And so there is a link, obviously. So if you've got someone who's got severe preeclampsia to the point where they're developing HELP, then they will be anemic. So
do you have any evidence in UK regarding anemia and eclampsia?
Well, the evidence comes through the fact that hemolysis and the subsequent anemia that you get with that it is linked to eclampsia. Whether we've done separate studies on that, I don't know, because it's part of the whole picture, if you see what I mean.
Sir, do you have any vision regarding the fantasies in the future, Professor P.C. Mahapatra, for this women's care, especially with reference to Indian women? Any other fantasies?
Well,
what do you visualize? How do you visualize?
I remember when I was a president in 2011. In January, I took charge, and in February, I wrote a letter to the Supremo. At that time, the Congress was the government. I wrote a letter to the Supremo that the first sentence I wrote that as a president of the women's organization in India, I am writing this letter and putting forward some of these my views. I am sure that this letter won't reach you. If at all by chance it reaches you, this is for your consideration for that. The first sentence I wrote that I wish that the pregnant women of India are the vital property of the government. And as a Supremo, as a lady, I am not finding any election manifesto or any of these strategies targeting specifically for the women's health issue. Then this really, I'm really feeling pity on you. And I feel, and I've written so many things, including this reproduction tax also. If you do not have a money, I will raise money for you and let the reproduction tax be levied on the time of marriage, and that can be sent as an insurance premium, and the whole thing can be covered with that. Well, if you see in the future, I think it should be a coordinated effort by the system, by the government agencies, as well as the healthcare provider and the community. And the three things must be coordinated to achieve a desired goal for that. So single-handedly, you as a healthcare provider cannot do it. Single-handedly, the government also by the plans and actions, they cannot do it. I think this could be a coordinated effort, concerted effort by the three main target areas. And therefore, if that can be done, I think the whole issues can be solved for that within a short time.
Sir, can you not visualize a system like NHS, like UK in India? If so, what are the hindrances? Like NHS in India. What is your suggestion, Eddie?
Unmute, sir. Unmute.
Please unmute.
There we go.
Yeah.
Yes. Introducing an NHS in India would be a challenge because to do that, you have to bring together all the health systems and you have to agree a certain way of reimbursing people who are providing care. There are benefits to an NHS, definitely, because you can join up the way in which you deliver care, but also you can collect information and use that to benefit. Now, I was very interested in Professor Mahapatra's sentence about criminalizing perinatal and maternal mortality. I would challenge that because we've shown in the UK that if you collect information around those sort of adverse outcomes and you find out why they happened in detail, and because the NHS joins everything up together, and then you look at the reasons why they happened, then you can make systemic change throughout the whole NHS very quickly, much quicker than a divided or federated health system. And so, when we've looked at things like the direct causes of maternal death, as Dr. Mahapatra was talking about, postpartum hemorrhage, eclampsia, things like that, we have significantly, almost eliminated the risk of death from those. Not quite, but we have done that by learning what led to those problems. And so now the main areas we're concentrating efforts to reduce maternal mortality is by actually looking at the medical conditions that women have, like heart disease, thrombosis, and things like that. So it's, I think if you criminalize these things, then people are less likely to say, yeah, I was part of that team where that woman died. This is what happened. I think we know how we can prevent that in the future. Because if you blame people, they go underground and they're less likely to want to learn. So I would gently say that whether it's a fact or a fallacy, I think it helps to have not a no blame, because there are sometimes when people deliver bad care, and sadly there are bad doctors out there and bad nurses. But if you've got someone who did not intend to lead to the outcome that happened, I don't think they should be criminalized, but they should be treated in a just way, so that if it happened unintentionally, they learn from that to try and prevent it from happening again. I think you're on mute now, Tushar.
Tushar is muted.
Tushar, please unmute.
Yeah. Is it audible?
Yeah.
So you are right, Eddie. I think in that way, it's not the proper time to criminalize something, especially to the obstetrician and all medical fraternity. So with this, I now hand over to our Professor B.B. Mishra, Vice Principal.
I, on behalf of the faculties of SCB Medical College and on behalf of the Dean and Principal, I really thank both the speakers, Dr. Edward Morris and Professor P.C. Mahapatra, for having wonderful presentation. Dr. Edward Morris has really presented what is the state of affairs in that country and suggested the guidelines. And what I was observing, Professor P.C. Mahapatra has enumerated what are the situations, difficult situations in our own country. And not only that, he has also exactly expressed the problems of the women in India. And I truly just say one sentence, that what he has thought as dreams are the dreams that what are the things to be done, but I feel this should be the realities of tomorrow and day after tomorrow. With this, I profusely thank both the speakers, the faculties, and I really thank only one person and one department, that is Department of Obstetrics and Gynecology, headed by Professor Tushar, who has taken lot of pen and harassed everything well, and today the attendance has reached the highest and the discussion was excellent. Now I invite Tushar to offer a vote of thanks on behalf of the SC Medical College again, as well as the Department of Gynecology.
Thank you very much. Thank you very much, Professor B.B. Misra, our Vice Principal. But I must here say that before beginning, this is a joke, lighter aspect of the lecture. Before beginning, I had a talk with Eddie that how many attendants should be there. You see, he was asking me. So you say he knows the Indian population, Indian audience, whenever he comes to India. He knows that. So now I hand over to my colleague, Professor Kirti Mahapatra, to give a vote of thanks.
Very good afternoon, everybody. It is a proud privilege on my part to convey vote of thanks in this August gathering on behalf of the Department of ONG SC Medical College. At the outset, I must thank our Honorable Dean and Principal Professor Dateshwar Hota for his untiring effort and his able leadership, which has made all these pre-platinum Jubilee CMEs a success. I also thank Professor B.B. Mishra, our Vice Principal, for actively presiding the latter half of the meeting or CME. I thank our international speaker, Professor Edward Morris from UK, the President of Rcog, to take his time from his busy schedule to have a nice talk, nice deliberation on challenges, new challenges in women's health in 2021. Nice, enlightening, and very educative deliberation, sir. Thank you, sir, once again. I also thank my teacher, revered teacher, Professor Dr. P.C. Mahapatra, ex-HOD and Professor, Department of OG, SC Medical College. Our revered Purna sir, as we call him, a very well-known and eminent personality, for his, as usual, nice talk, sir. It is really mesmerizing. We all lost the time. What are the nice? It was a nice talk, sir. All about the fantasies, fallacies, and future of our Indian women, health of our Indian women. I must thank our HOD, Professor Tushar, for his hard work, starting from arranging the speaker to rescheduling the meeting so that to make it a very successful CME. I thank you, sir, for your flawless arrangement, proper coordination, and nice moderation to make it a success. Thank you once again, sir. And I also thank Professor Vidyut Das, in charge of telemedicine, for his immense help for making this CME a success. I thank all faculties, all HODs, all residents of this SCB to join and make it and actively participate it and make it a success. I also thank the consultant from Odisha, outside the Odisha, outside our country also, who have joined. Really, the attendance today is the record number. This is precious 370. So it is, we are very thankful to all of them who have participated actively and joined and making it a success. And last but not the least, because it is most important, I must thank Mr. Devashish Panigari, who is the, yes, He's the man behind the screen, but responsible for very efficient management with so many international personalities, international speaker as well as international delegates in this platform. Thank you again. And thank you all.
All the participants have enjoyed very much, with especially our international speaker, Dr. Eddie, as well as our Purna sir, PC Mahapatra. Again, I thank on behalf of Obstetrics Gynae Department, SU Medical College, and all SCBs. Thank you again, Eddie, for long distance you have come, at least in the webinar.
Thank you. It was a pleasure. Real pleasure. Lovely to see everybody.
Eddie,
Thank you.
We'll meet soon. We'll meet soon
Thank you.
again.
So
We will.
You remember that 29, you got that, you see, our fellowship, honorary fellowship. You remember January?
I do. My last travel abroad.
Yeah.
Goodbye, everybody. Thank you very much.
Bye-bye. Bye-bye.
Thank you.